Okay, welcome everybody. Welcome, welcome, welcome to this clinical discussion. Do come on in, and we'd love to know in the chat where you are joining us from. So I'm Joanna, and I am joining you from York in the UK. And Neil, where are you joining us from?
I'm in Courtney on Vancouver Island in British Columbia, Canada.
Fantastic. So wonderful. Oh, Diana from New York City, welcome. Saskia from San Francisco, Elizabeth from Hong Kong, Amber from Calgary. Isn't it great? I love the fact that we get everybody from around the world. Julia from New York City, welcome, welcome, welcome. Thank you, everyone, for coming on in. Do let us know in the chat where you join us. Sue Horton from Seattle, Nicola Gill from York. Hi, Nicola, down the road, probably. Uh, Leah from Saskatoon, welcome, welcome, welcome. Fantastic. Look at this. Julie from Montreal, Steve from Las Vegas. Oh, here they go. It goes too quickly now. Sarah from Dorset, UK. That's wonderful. So, what's the weather doing this very early morning for you, Neil?
It is a cool morning, like 8 or 10 degrees out there, and sunny, which is really nice because I live in a rainforest, so it's great that it's a sunny day.
Lovely. Oh, that's great. And it's absolutely roasting hot here in York in the UK. I think the whole of the UK is really, really hot, which is unusual for us. So
Hmm.
that's good. That's good to hear. Okay, we are going to kick straight off because we invariably run out of time in these sessions, and I am so excited to have Neil Pearson on this clinical discussion. So I've been looking forward to this one since we set it up. I can't wait to get started. Okay, so for anybody that hasn't joined us before, a very warm welcome to this NOI clinical discussion. My name is Joanna Taylor, and I am Director of NOI Group in Europe. And tonight, or this morning, I am joined by a very special guest. I say special because this is his first time on the clinical discussions, and I have a feeling it won't be his last. So thank you for joining us, Neil.
You're welcome. Pleasure to be here.
Neil Pearson is a physiotherapist with 40 years of clinical experience. He is a clinical associate professor at the University of British Columbia, founding chair of the Canadian Physiotherapy Pain Science Division, and recipient of the Canadian Pain Society's Excellence in Interprofessional Pain Education Award. That's a bit of a mouthful. It's impressive as well. Fantastic. But what makes Neil truly distinctive and what we're going to be drawing on tonight is his background as a certified yoga therapist. Neil has spent his career at the intersection of pain science and embodied movement. And that combination gives him perspective on pain and movement that I think is genuinely unlike anybody else that we've had on the clinical discussions. So it's wonderful to have you here, Neil. Would you be kind enough to just tell everybody a little bit about what you are doing currently in your professional career? Thank you.
Sure. Thanks, Joanna. Really wonderful introduction. Um, so clinically, 3 days a week, I work in a interdisciplinary pain management program, specifically for veterans, and
Mm.
specifically for veterans who have musculoskeletal injuries, mental health issues, and often substance use issues as well. So it's quite a complex situation. Actually, I would say that almost like the hardest job I've done sort of cognitively and emotionally, just because of the
Mm.
expansiveness of the issues that are going on. I also am part of, I guess I'd have to say part of a research team
Mm.
with some researchers looking at knee osteoarthritis. And I got brought on because of my interest in yoga. So we actually are looking at sort of yogifying the GLAD program for knee osteoarthritis to see would that make any difference if we added those things in, as well as some pain science. And the thing we're going to talk about today, a little bit about the interoceptive movement guidelines. We're doing some research to see if you get people to use that kind of a guideline, will it give people better results from exercise when they have knee osteoarthritis?
Okay,
So
fascinating. Really
yeah, so
interesting.
so I'm sort of doing a little bit of the research stuff, like sort of on the side, but mostly clinical practice. And as we were talking about just before everyone got on, is that I'm going to start teaching some therapeutic yoga classes again in the next few weeks, which will be a real joy.
Amazing. Thank you. Thank you very much. Fascinating. So just a couple of quick housekeeping things before we get stuck in. Neil and I are going to be talking for about 20 minutes. If you have any questions, please do drop them in the chat and we will answer as many of those live as we can. I would urge you to get your questions in sooner rather than later because we often run out of time. The recording of this session will be available on our clinical discussion YouTube channel. I'll drop the link for that into the chat in just a second. Just like, subscribe, and then you'll be notified when any new videos are uploaded. And oh yes, there's a growing library of sessions on there, and I think there's 60 or more now on loads of different topics. It's growing all the time, and it's fantastic. So it's a great free resource. Okay, so let's get going. Question number one. Neil, you spent your career at the intersection of pain science and yoga therapy. That's a fairly unique combination. Could you tell us a little bit about how these two worlds came together for you and how it has shaped the way you think about pain and movement?
I think that really where it started for me was with an interest in meditation. I've
Mm,
sort of had this very long interest in learning more about that. And then in 1997, I actually moved to Vancouver. And when I moved to Vancouver, I ended up working at a pain management center there. And a number of the people who were there were actually involved in some meditation and also involved in yoga. And they basically said to me, if you like meditation, you're going to like yoga. I'd never gone to a yoga class. I really knew very little about it. And of course, it was Vancouver. There's like yoga all over the place in Vancouver. And so my experience was when I started to do the yoga practice, because I went to a yoga studio that just by chance the teachers were really sort of embedded in yoga philosophy and trying to bring the yoga philosophy into the actual practice of the physical postures of yoga. And I started to realize that the things that they were talking about and the things they were getting us to do were very similar to what we were doing in the pain management center. So
mm,
it was like, almost I could see like a similarity between, hey, when we do that posture, we're doing this, or when we're asking people to breathe in a certain way or have certain thoughts and seeing it happening over there. And so I just got
mm,
more and more interested in that, really the intersection of pain management, what we're doing with pain management and pain care, and what we're asking people to do, what yoga philosophy is suggesting people do.
that's brilliant. Thank you. And just what sort of, could you give us an example of something that one of the things that really stood out to you about the overlap?
Okay. Well, one of the things that within yoga practice, one of the sort of steps of yoga or one of the aspects of yoga is actually where you're taking your attention away from the external world and bringing it inside.
Okay.
And so in yoga, it's called pratyahara. We call it interoception. But
Mm,
there's this big overlap between the importance of these things. And I was sort of early on working in the pain management center. And maybe because I was getting people to do body scans and body awareness practices, but
mm,
a lot of people were telling me that they had a sense that their body size or shape was different from what it actually was. So sort of
yeah.
a distortion of sense of body awareness or body image. And so I was hearing that a lot. And then there over here within yoga, there were these practices that were attempting to get you to recognize that a lot of times that you experience is actually an illusion or a delusion, and also get doing things that would help you to sort of rebuild your sense of your body back to where it was before.
Yeah, that's fascinating. Thank you.
Mhm.
Um, the title of this session is Pain During Movement and about it being too much.
Mm.
So the idea that pain during movement isn't always a signal to stop. How do you get curious about, how do you help patients to get curious about their pain rather than afraid of it?
Right. Um, as you ask that question, the first thing that pops in my mind is the whole idea of curiousness.
Mm,
Um, when I'm working with people, when I'm trying to teach people about pain science, to provide this, education to help people reconceptualize things. My very first goal is actually to help the person to be curious about what they think about pain.
Mm,
Because we don't normally sit around and think about what we think about pain. And so rather than having the goal of trying to get the person to reconceptualize pain at the beginning, it really is just get them to be curious about their thoughts about pain as the first step in. And so when we're getting people to move around, I think is that same idea is how do we get people to maybe take a different approach? And I mean, first idea that I think of when you ask that this morning is, maybe it's just working with the person saying, I know you've tried to move, right? If you've come to see me, you have
mm,
tried to recover functioning already. And so, I would ask the person to tell me, like, what was your approach? What were you trying to do? People often we see those extremes of the fear avoidance or the people who have just grit their teeth. And working with veterans, the vast
mm,
majority of them do not stop until the pain is like extraordinarily high because they've
mm,
just learned to have that capacity. And so, okay, so that's the approach that you worked, and you're telling me it didn't work. Okay, would you be open to trying a different approach? Just sort of following that sort of logic is often, at least in the people that I'm working with now, it's a common thing that I'm doing. Is really
yeah.
just, affirming to the person that you tried to change this, right? And whatever approach um, that probably worked before for you, but it didn't work this time. So how
Mm,
about we just try some different things? So I sort of
mm,
move it that way. Um, I guess with a lot of the people that I work with, I bring breathing techniques in really early, which usually gets a whole lot of curiosity or resistance from people right off the bat, right? Because the person comes in with lower back pain and I start to get them to a breathing technique, can have
yeah.
this experience of like, did you actually listen to anything that I said? I mean, I've just told you about this horrible back problem and you're asking me to do a breath practice. And of
Mm,
course, it's the then trying to get them to understand, why we would be doing this, how important it is to try to find a way to regulate our physiology, and how
mm.
regulating our physiology could be helpful. And of course, that then starts to when we start to talk about DIMS and SIMS and all the other aspects of this.
Okay, because that was a question that I wanted to ask actually, and it was about how do you get people past that
Mm.
fear of the movement and the pain
Mhm.
caused by the movement, and how
Right.
would you approach that with a patient?
Well, maybe I'll just sort of take you through the whole sort of approach. It's
Yeah.
it's very it's interoceptive. The idea is to get people to pay more attention to what's happening inside. Um, but I'll sort of
Mm,
maybe I'll explain it a little bit this way. So what I'm trying to do is use some of the ideas of pain science. So pain science tells us that the first increase in pain is not tissue damage, right? The first increase in pain is always the system saying maybe that's enough for now, kind of thing.
mm,
Right. So we know that going to the edge of the increased pain, we know that that's safe. We also know from science that pain itself isn't accurate. Using pain as your guide for when to stop also is not a good, it's not a great idea
mm,
because pain's not accurate. So we need to have something else. We also know that the body has many ways to protect itself. Pain is just one. And so we could potentially listen to other alarm systems. So one of the things that we've asked people to do is to, all right, so as you're doing this movement, say a person has lower back pain and they're
mm,
saying, I can hold a weight here. I can hold like 20 pounds here, but as soon as I take it away from my body, that's where I start to feel the fear, or that's where I start to have the pain increase. And
mm,
so we might, get them to move the weight away and say, well, just go to the spot where the pain just starts to increase. And when you get to that place, what I want you to do is ask yourself the question of, does this feel safe? And if it doesn't feel
mm.
safe, then let's move you to a spot as the start of where you do feel safe. So we're working on the cognitive sense of safety, right? The conscious cognition of, yes, I need to be in a place where I'm safe. And the idea would be is if you don't feel that you're safe, well, this is going to increase the hypervigilance of the systems, right?
Yeah.
This would be a threat message. But then to ask the person the second question was, which is, will you be okay later? So if you go to this edge of the increase in pain and you say you're safe, but ask yourself, do you think you're going to be okay later? And with the veterans, this is really important because a lot of them
Mm,
say, I know I'm safe right now, and I think I'm going to pay for this later on, which probably means that
mm,
they've gone way past the edge, right? They've probably gone too far. So we need to
mm,
find that. But then we say, all right, so once you're there and you're at that edge of the increase in pain and you've asked, am I safe? Will I be okay later? And you're answering in the affirmative, the next thing to do is to calm down your breath. Like check in with your breath and can you actually calm your breath?
mm,
Because if you can't calm your breath, again, there's probably a message of threat around that, right? If your breath is getting tight or short or shallow, that's we have this idea that that's a physiological and like an internal physiological message of threat. And
mm,
then the next thing is to ask people to do it with calm body tension, right? So can you actually release tension in your body, or are you in a place where that's possible? Again, trying to work on this idea of if you can calm your breath, if you can calm your mind with those two questions, if you can calm your body, that we're hoping what you're doing is you're increasing the evidence of safety. And that when the people do this, they often will report back is, I can do more. I can actually move further when I do this. Right? It's almost like the
mm.
edge sometimes even moves further away when people calm their body and calm their breath.
Yeah.
And so the message trying to give the person is, well, if you can do this with more ease, or if you can do more of this without provoking the pain now, well, now you actually can put more force on your body to help your body get better.
Yeah.
Right. So tying it back to that message, I think is really, really key to people is the reason that I want you to pay more attention to these internal signals is
Mm,
so that you can actually do more with your body because we got to get your body healthier again. And of course,
mm,
for those people who are listening who know the fit for purpose model, this sort of seems to fit really, really well because it's working
yeah.
on the conscious part, on the autonomic part, and on the tissue part itself.
Yeah. Fantastic. That brilliant. I think, Saskia, we may have just answered your question, but I'm just going to ask this question anyway, just to see if Neil
Mm.
can elaborate any further. Saskia says, how do you teach patients to differentiate between pain and the normal discomfort of muscle exertion during exercise?
That's a great question.
Yeah.
Um, I don't know that there's like I'm thinking about these guidelines. These guidelines tend to differentiate that.
Mm,
Because it's actually, the guidelines of move to the edge, am I safe? Will I be okay later? Can I calm my body, calm my breath? It actually doesn't matter whether it's normal or not. You're still trying to find a way that a person can do it so that when they're doing the exercise, they're not pushing beyond. They aren't leaving themselves provoked when they're done.
mm.
Um, but I'll need
Is
to
it
put
to
some
do
more
with
thought into it.
safety? Is it to do? I thought that was brilliant what you said
Mm.
there about the safety feeling. So you're measuring
Mm.
when they feel safe.
Yeah. Well, and I think if a person is feeling the things that we would say are normal increase in normal sensations of just effort in the body, um,
Mm,
they're going to meet all those criteria, right? When people are
mm,
there. Um, so I think the same guidelines. I guess what I would say is maybe just when that's coming up, if you try these guidelines and see what happens, that you may find that you don't need to answer that question as much. Because
mm,
part of what I'm just sitting here experiencing is that um, I can't remember having to address that question in a long time in my clinical practice. So I think what I'm doing must be getting around it. And I haven't thought about this. Why has this not come up for me in a long time?
mm. Yeah.
Hmm.
Thank you very much. And thank you, Saskia, for the question. That's great. I have another question here from Avril. Um, and it is, are any of your patients neurodiverse, and does that affect interoception or pain sensations?
Um, so the answer would be yes and
Yeah.
yes. Yes, I have people who are neurodiverse, and does it change things? It changes
Mm,
things a ton. Um, I think I think we see a lot of people who um, are really disconnected from their body.
mm,
And I think when we see people where there's they're neurodiverse, I think that we're seeing people who have a different relationship with their physical body than others. And so
Mm,
I think there's a whole different approach. And this is another area that I'm just starting to learn about. It's not an area that I think um, has been on my radar a whole lot or that I've thought a lot. But I've
yeah.
been starting to recognize in the last couple of years that there's some people that we need to work far more with the psychologists and the counselors to give us more assistance
Mm,
in how do we modify what we're doing to actually make it beneficial for this individual.
mm, yeah. Uh, Interesting. It's definitely something that we need to be increasingly aware of,
Mhm.
isn't it? Absolutely. I'm just going to go back into the question thread that we have, and then I'll have a look and see. But we've got lots of questions coming in, which is wonderful. We love getting questions. Dosing is one of
Mhm.
the trickiest things that we always get asked about. Dosing too little, and you're not making progress. Too much, and you risk setback or loss of trust. How do you help? How do you dose? How do you help clinicians
Mhm.
dose within this framework that you've been talking about?
Well, I think the interoceptive guidelines make it easier to figure out the dose that will be okay. Like that
Mm,
idea of finding out of not going too far. Um, that the longer people practice this, the better they actually become at interoceptive awareness. So
mm,
people often start to say as they practice this, I used to think my edge was here, but now I realize when I thought my edge was there, it was actually way down here. Had just learned just to bypass it all this time. And so I think that using the guidelines, people start to figure out for themselves how to dose this better. Um, can't help talk about the idea that the research really doesn't have a lot of helpful answers for us on how much to do. In terms
yeah.
of pain, I think the interoceptive guidelines will help us with the dose, but the other thing we're trying to do is change the nervous systems. So we need to figure out how much repetition
Mm,
in a certain session and how many sessions a day. Like how do we figure those things out?
mm,
I think we need to figure out, what is the dose for changing the nervous system, and it usually means higher reps, right? More, doing something more times,
yeah.
which I think again with the interoceptive guidelines, it usually gets people to actually start to do less activity, which is annoying for some people. We need to work around that because they're like, if I follow these guidelines, I'm actually doing less than I was before. And
Yeah.
I say, well, yes, because what I want you to be able to do is to do enough repetition that you'll actually change the nervous system. Because the way that you were approaching this before, you
Mm,
really couldn't do
yeah.
very much. And so you're not getting that neuroplastic change that we're hoping for. And of course, if you can't move very much, again, like the moving the body in repetitive ways is the way to actually get the body to change too.
Yeah. Yeah. But that's fascinating. You sort of partially answered my next question, which was we were talking about, say, veterans, for example, and that they have this tendency to just push, really push themselves. How do you cope with that in patients when perhaps you feel like they're pushing too much?
Um, I think it's coaching. I think it's just
Mm,
being with the person, recognizing that, especially in the veteran world, that people have been told not to listen, to keep on going. And a
mm,
lot of times we hear veterans say, I got through this by compartmentalizing, which mostly means that they got through it by disconnecting or dissociating.
mm,
And so if we start with the idea that understanding someone who's been through that life experience is likely going to go way past. And it's just a matter of realizing that's what they've done, and we're going to have to, work over time at getting them to slow down to get them
mm,
to improve. Um,
mm.
yeah.
Yes, thank you. Thank you. That was a really great answer. So I've got a question here, and my mouse has just died. So I can't see who it's from because I can't scroll down. I've
No.
just plugged it in to charge it up. And this question says, I have encountered many people in chronic pain and they don't want to quieten down and pay attention. It increases their experience of pain. So how do you address this tendency to not want to pay attention to the sensation?
Mm. Yeah, I think that's a really, really good point. And I think there's also we can take a step further. It's not just a not wanting to. Some people will try to do it and have significant adverse effects, right? We
Mm,
sort of have this idea that you know, everything's going to work for everything. And getting people to be to attend to their breath more, to attend to their body more, can actually make some people more anxious,
mm,
can make people angry. And so we would need to find another way around, right? We still have this idea of how do we get the person to, move in a different way and approach movement in a different way and approach their care in a different way. But sometimes we're not going to be able to use these interoceptive guidelines because
mm.
nothing is a panacea. There's actually a psychologist in the United States. Her name is Willoughby Britton, and she has a website that's actually all about the adverse effects of contemplative practices.
Okay.
So I think that's where we need to start is to recognize that if we're getting people to pay more attention to self, we need to be very aware that sometimes this will actually worsen a person's situation. And if it is, we need to stop.
Mm,
I just think of an example, a related example. Years ago, I saw a woman who had been taught to do diaphragmatic breathing by somebody for a back and neck problem that she had. And so I said to her, "Well, how often do you practice it?" And she said, "Well, I practice it 3 times every day." And well, what was the effect? And she said, "Well, every time I do it, it actually makes me more anxious."
yeah.
And I thought that, I just needed to keep on practicing it until it would actually, at some point it would make me better. But she'd been
Mm,
practicing it for months, right?
yeah.
So I think we need to watch for that is recognizing that these things may not get us what we want to get. We may need to go in different doors. And
Yeah.
and I think that's where we need to join together with people who work in the clinical counseling and psychology area to get some ideas of when this is happening, what approach should we take?
Yeah.
Um, because I don't feel it's within my fully within my competence from my training to know exactly where to go when people are in that situation, which is really
Mm,
hard if you're a physiotherapist working on your own rather than in a team. But to recognize sometimes people need more than we can offer if their nervous systems are that dysregulated.
yeah.
Um, I guess the one other thing that I would point out is that, we often try to get people to do techniques that we put in the mindfulness category or getting people to be present. Even these techniques can not be effective for some people. And so sometimes what we need to do is get people to do like sort of more embodied mindfulness techniques. So if you ask a person to like take a tennis ball and just bounce it and catch it with the other hand and bounce it and catch it with the other
Mm,
hand, and ask them, pay attention to the sound of it hitting the floor in your hand and pay attention to the feeling of hitting your hand. This is actually a mindfulness technique, but it's an embodied technique. And it's interesting for me with the veterans, there's a lot of them, if I ask them to sit and just and be present with their breath or their body sensations, they really struggle. But I've asked
yeah.
them to be present with a movement like bouncing a ball or juggling a ball or doing things like that, that a lot of them are far more successful there.
That's fascinating. Thank you, Neil. We have nearly run out of time. I knew this was going to go really quickly because I'm really, really interested in what you've had to say. And that we're just going to wrap up now. I'm sorry we haven't got to everybody's questions because there were quite a lot today, more than often we do get. So that's absolutely brilliant. Thank you so much. And thank you to everybody for joining live and for watching. I'm sure we've all got a huge amount to take away from that. Tonight's session has got you thinking, or this morning, wherever you are, and you want to go deeper with Neil. He is one of the instructors on a brand new course that we are bringing to both the European and Canadian time zone called Embodiment in Pain Science Education, which he co-teaches with Martina Egan-Moog. The first one that we ran this just weekend, it sold out within a week, I think, which was unbelievable. So we put another date on, and we've got the next date is planned for the 18th of June, I believe. I think that's right. So I've dropped the link to the chat, to the course into the chat. Please do click through, check it out. Neil, just very quickly before we head off,
Mhm.
could you tell us a little bit about that course and what people might expect to come away with if they choose to do it? It's just 3.5
Mhm.
hours, I believe, so it's a short
Yes.
short course, which is really really lovely. And what might people expect to learn and come away with?
Mhm. Probably the big thing that people will come away with is what do we do when a person is a patient we're working with is struggling to reconceptualize pain? And so what we're trying to do is talk about how we would use embodiment and embodied practices that actually would help people to either learn the concepts of that we're trying to get people to reconceptualize
Mm,
or to reinforce or deepen that understanding. So we start by explaining what embodiment is, because there's a lot of people saying embodiment is different things. And so we sort of dive into really what is embodiment and a little bit of the philosophy of that and how we can make that practical. Then we talk about how we could actually use embodiment to reinforce or provide some of the key messages of pain science education and then quickly take people through the movement guidelines, the interoceptive movement guidelines we've talked here,
mm,
but also take people through three other embodied practices having to do with breath and body awareness that would help
mm,
that. Sorry, and we give you scripts for these as well that you could then go and use these with your patients to try to help them to have that felt sense that would actually lead them to reconceptualize pain. That's
amazing.
basically what we're doing.
Such a cool course. We spoke about this before we came on. I'm really excited by this. I think it's fresh and it's really a direction that people have been looking for a long time to bring the body back into treatment. Thank you,
Mhm.
Neil. I've
Yeah.
thoroughly enjoyed that, and I know that our audience has too, because we've had a lot of engagement and a lot of thank yous coming in already. So, thank you to everybody who's joined us live, and thank you for your brilliant questions. Don't forget to go onto the YouTube channel, check out the other clinical discussions that are on there. They cover so many topics, and we'll be inviting Neil back in the near future for another one. I've really enjoyed it. Thank you so much. Take care, everyone, and enjoy the rest of your day or evening wherever you are. Thank you, Neil.
Thank you, Joanna. It's been a pleasure.
Thank you.